Our goal here is always to give you the essential knowledge to be well-informed. And today, we are tackling a fundamental truth of modern medicine.
That every medication is a calculated gamble.
Exactly. We are diving into the science of unintended consequences. How, why, and when pharmaceuticals go wrong.
And our mission today is to really get to grips with this. We want to clearly categorize and understand adverse drug effects, look at the mechanisms behind them, and then explore the complex global systems designed to keep us safe.
Right. The whole world of pharmacovigilance.
It's a deep dive that touches on chemistry, pharmacology, and, well, the messy reality of individual patient biology.
So where do we start? The source material seems to insist on getting the language right first.
It does, and for good reason. When we look at the source material, the first step is achieving absolute clarity on our vocabulary. In regulatory science, these definitions aren't just, academic preferences.
They have real-world consequences.
They determine whether an event triggers a report, a safety warning, or even a full drug withdrawal.
Okay, let's unpack this immediately. Let's start with what the sources call the 3 A's, which I think people often use interchangeably.
They do. We're talking about adverse effect, adverse drug reaction, and adverse drug event.
Let's start with the widest possible net. Adverse effect, or AE.
So the adverse effect is the broadest term you can possibly use. It's defined as simply any undesirable or unintended consequence of drug administration.
Any, y'all.
Any. And crucially, it implies nothing about severity or causality. It's the ultimate catch-all.
So if I take a pill and feel a little bit dizzy,
That's an AE.
and if that same pill causes major organ failure,
That is also an AE. Trivial or fatal, it doesn't matter. It all falls under the huge umbrella of an adverse effect.
okay, so AE is just describing something that happened that we didn't want. Now, let's get more specific with adverse drug reaction, the ADR. This is where we start to point a finger, right?
Precisely. The adverse drug reaction, or ADR, is a much narrower and I'd say more clinically significant term.
Why more significant?
Because it's what we use for detection and quantification. An ADR is defined as a noxious change, which is suspected to be due to a drug, and this is important, occurring at doses normally used in humans.
So, not an overdose.
Exactly. This definition is the core of safety science because it implies a suspected causal link, and it filters out effects from gross overdoses or poisoning.
So, an event only becomes an ADR if it's serious enough?
Serious enough to require action. It has to require treatment, a dose decrease, or at least a note of caution for using that drug in the future.
So an ADR isn't just a mild headache. It's a headache so bad that the doctor has to change your prescription.
Yeah.
It's moved from being a curiosity to a clinical problem.
That's a perfect way to put it. The causality is suspected and the dose is standard. This is the definition that regulators really care about when they're thinking about changing labels.
But then we have the third term, the adverse drug event, or ADE.
Yeah.
Now, if ADR is already focused on causality, why do we need this other term in pharmacovigilance?
Well, the adverse drug event is essential for practical monitoring, and it's a bit counterintuitive, but it's actually the broadest term used in the reporting context.
Broader than AE.
In the context of monitoring, yes. An ADE is any untoward medical occurrence that may present during treatment with a medicine. The key distinction here is that, unlike an ADR, causality is not necessarily implied.
Okay, why would you structure it that way? It seems like you'd just get a lot of noise.
You do, but it's a very pragmatic approach to gathering data. The pharmacovigilance, or PV, centers, they don't want to rely on the reporting physician's initial, often rushed assessment of whether the drug caused it.
They just want the data.
They want to cast a massive net. If a patient is on drug X and they fall down the stairs, that's an ADE. If drug X is known to cause dizziness, the system might later connect those two events, but initially, the PV center just records every single undesirable thing that happened while the patient was on the drug.
So you don't miss anything.
You ensure no potential signal is missed just because the link wasn't immediately obvious. The philosophy is, record everything, and we'll analyze the noise versus the signal later.
That makes perfect sense. So now that we have the definitions down, let's talk about why we need this incredibly elaborate system at all. The sources make it very clear that all drugs carry some level of risk.
Absolutely. No drug is perfectly safe. The clinical decision to use any drug requires this crucial balancing act. You're weighing the magnitude of the risk against the magnitude of the expected therapeutic benefit.
You, as the patient or the clinician, are constantly making that calculation of what's acceptable.
All the time.
Can you give an example of how the severity of the risk can change that calculation?
Certainly. The source material provides a really clear contrast. Let's take the risk of bone marrow depression, a severe, potentially fatal adverse effect.
A very serious risk.
Very serious. But if the patient has a life-threatening cancer, the alternative is certain death. So in that context, the risk of bone marrow depression might be completely justified. The benefit massively outweighs the risk.
Okay, that's an extreme case. What about something more common?
Well, let's consider mild drowsiness caused by an antihistamine for hay fever. A very minor AE, you'd think.
For most people, yeah.
But what if the patient is a commercial truck driver, or an airline pilot, or anyone who operates heavy machinery? Suddenly, that mild drowsiness becomes an absolutely unacceptable risk.
So the risk itself hasn't changed, but the context has.
The context is everything. The patient's life and the lack of severity of the underlying condition, it's just hay fever, means the balance tips away from using that specific drug.
And the sources emphasize that these events are not rare at all. The incidence is much higher than most of us realize.
They are very common. Incidences of 10 to 25% have been widely documented across different clinical settings.
Especially in certain populations, right?
Particularly among the elderly, who often suffer from polypharmacy.
Meaning they're taking multiple drugs at the same time.
Multiple drugs, which increases the risk of interactions and adverse effects exponentially. This high incidence is exactly why we need to classify them, which brings us to the two major types of drug reactions.
This feels like a huge pivot point in our discussion, moving from the general system to the specific mechanisms. We divide all reactions into two huge groups, predictable versus bizarre.
Or type A versus type B, as they're known in pharmacology.
I want to start with type A, the predictable ones. They're also called augmented reactions.
Type A reactions are really the workhorses of adverse effects. They're the most common, accounting for up to 80% of all reported reactions.
And the mechanism is key.
The mechanism is fundamentally rooted in the drug's known pharmacology. It's an augmented but qualitatively normal response.
Meaning the drug is doing exactly what we expected it to do, just a bit too much of it.
Precisely. If we give a beta blocker to slow the heart, a type A reaction is the heart slowing down too much, causing bradycardia. They are inherently dose-related.
Which means they're mostly preventable.
Mostly preventable by adjusting the dose, and they're generally reversible once you stop or reduce the drug. This category covers common side effects, toxic effects from high doses, and also the consequences of withdrawal. Because they operate on a known biological pathway, they're highly predictable.
Okay, so if type A is all about predictable pharmacology, then type B, the bizarre reactions, must dive into the chaos of individual patient biology.
That's absolutely right. Type B reactions are the outliers. They are based entirely on peculiarities of the patient, something unique about their biochemistry, often their genetics or their immune system.
So it's not based on the drug's established mechanism of action.
Not at all. They're much less common, maybe 10 to 20% of reactions, but they are often non-dose related.
What does that mean exactly?
It means a tiny amount of the drug can cause a catastrophic event. And they are generally much, much more serious. They always mandate immediate drug withdrawal.
So we're talking about things like allergies and what the sources call idiosyncrasy here. These must be the reactions that clinical trials are worst at catching.
They are, because you need massive exposure across very diverse populations to find them.
But science is catching up.
Yes. And here's where the cutting edge of science comes in. The source makes a really intriguing point. While these are currently classified as unpredictable type B reactions, if we can identify the specific genetic basis for one.
Like a faulty enzyme or something.
Exactly. Say a deficiency in a certain metabolizing enzyme. Then we can create a simple genetic test. And by knowing the patient's unique genotype beforehand, we can predict and prevent the reaction entirely.
So pharmacogenomics can take a type B bizarre reaction and make it predictable.
Conceptually, yes. It shifts the unpredictability from the drug's mechanism to the patient's genotype, which is something we can now screen for. It's a profound shift in risk management.
It really is. The ultimate goal, then, is to move as many unpredictable reactions as possible into the predictable and manageable column.
That's the dream of personalized medicine.
Before we explore those mechanisms in more detail, we have to talk about severity grading. Because, a mild rash and full-blown anaphylactic shock are wildly different problems for regulators.
And severity grading is crucial for those regulatory bodies like the FDA or the European Medicines Agency. It's what allows them to prioritize drug alerts and decide if a drug needs to be pulled from the market. The grades are pretty much universally standardized.
Okay, so let's walk through them. We start with minor reactions.
Minor reactions require minimal intervention. We're talking no therapy, no antidote, and they don't prolong hospitalization. They're annoying, but not medically demanding.
Then we have moderate reactions.
These require a significant response. A moderate reaction means you need a change in drug therapy, you have to start a specific treatment like an antidote or supportive care, or it prolongs the hospital stay by at least 1 day.
So this is where the reaction is now noticeably impacting the patient's clinical course.
And adding costs and complexity to their care.
Yes. And then we get to severe.
Severe reactions are potentially life-threatening. The patient could die without immediate intervention. They might cause permanent damage, or they necessitate intensive medical treatment, maybe a transfer to the ICU.
And finally, the worst outcome, lethal.
Lethal reactions are those that directly or indirectly contribute to the patient's death. When you see regulators issue those urgent warnings or withdraw a drug from the market, they are primarily reacting to the frequency and nature of severe and lethal reactions.
That sets the stage perfectly for the massive infrastructure that's designed to track all of this. We are now moving into the system of safety, pharmacovigilance, PV.
Pharmacovigilance is, well, it's the global detective work necessary to police medicines after they've left the highly controlled environment of a clinical trial.
It's a great way to put it.
The World Health Organization defined it back in 2002 as the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problems.
It's the entire architecture built around the fact that clinical trials just can't find every single safety issue.
They can't. A typical trial might involve a few thousand patients for a limited time. That's not enough to catch a reaction that happens once in every 10,000 patients or one that takes 5 years to show up.
So the main purpose of PV is singular, really.
It's to reduce the risk of drug-related harm to the patient and, fundamentally, to provide the basis for assessing a medicine's safety, which promotes rational and safe use.
Let's talk about the key activities. The core of it seems to be post-marketing surveillance.
Yes. Post-marketing surveillance is the ongoing monitoring after a drug is released to the public. And the most fundamental component of this is voluntary reporting by health professionals.
Like the yellow card system in the UK?
Or MedWatch in the U.S. Health professionals, doctors, pharmacists, nurses are encouraged to report suspected adverse drug reactions, ADRs.
And this is where we hit what I find to be the most concerning statistic in all of the source material. It feels like the Achilles heel of the entire system.
I think I know what you're referring to, the underreporting issue.
Yes. The source material highlights that even in developed countries, only about 10% of ADRs are ever reported voluntarily.
And in many parts of the developing world, that number is far, far lower. It's minimal.
Only 10%. That sounds dangerously low.
Yeah.
I mean, if the whole system hinges on this data, are we essentially flying blind on 90% of what's happening out there?
It's a real challenge.
It is.
But perhaps not as catastrophic as it sounds, though it is certainly a major limitation. The system is effective at catching the rare, dramatic, and immediate events.
The type B reactions.
Exactly. If a new drug causes anaphylaxis in 3 patients across the country, that event is so dramatic it's very likely to be reported.
So what does the system miss?
It misses the subtle, common, or non-immediate reactions, especially if they mimic the symptoms of other common diseases. A little bit of fatigue, some nausea. It's easy to dismiss.
And it's not just apathy from clinicians.
No, it's also systemic. A busy doctor might not even recognize the causal link, or they may simply not have the 10 minutes it takes to fill out the form. So the system is great for detecting a signal, the possibility that something is happening, but because it's voluntary, it can never give us an accurate incidence rate for that reaction.
So once they gather this patchy data, what's the regulatory outcome?
The PV centers consolidate the data and they disseminate the information globally. They send out drug alerts, medical letters, advisories. This leads to regulatory action, which can be anything from a minor change
Like adding a warning label about drowsiness.
to major changes, like restricting a drug's use in pregnant women, or in the most severe cases, the complete withdrawal of the drug from the market.
And this has to be a global effort.
Absolutely. The Uppsala Monitoring Center in Sweden plays a critical role here. It's the international collaborating center that standardizes data collection and analysis across dozens of national PV programs.
And they use specific tools to do this.
They rely on assessment tools. They use standardized algorithms for causality, like the Naranjo algorithm, and established rating scales for severity, like the modified Hartwig scale.
That Naranjo algorithm sounds critical because defining causality has to be the hardest part of the job.
It is.
I mean, when an adverse event happens, it could be the drug, it could be the underlying disease getting worse, an interaction with another drug. A clear yes or no must be incredibly rare.
It is. A definitive lab-proven causal link is often impossible to establish, especially outside of a controlled study. So causality assessment relies on gathering strong circumstantial evidence, which is categorized by 4 primary criteria.
The first one is the temporal relationship.
This is fundamental. How does the timing of the event relate to when the drug was given? Did the event happen shortly after the drug was started? Is that timing consistent with what we know about the drug's properties?
So if the drug takes a week to reach full effect and the reaction happens in 1 hour, the link is suspicious.
Or at least less likely, yes.
The second criterion is previous knowledge.
Has this reaction been seen before? Is this drug already known to produce this specific event in other patients? If the reaction is already documented on the drug's label, the probability of a link increases significantly. This is where those 10% of voluntary reports, while limited, build our collective knowledge base over time.
Okay, the third is de-challenge.
This is very strong evidence. If the suspected adverse event went away when the drug was stopped, the act of de-challenge, that strongly suggests the drug was the cause. If the problem disappears when you withdraw the drug, the link is considered probable.
And the fourth, which seems like the most definitive of all, is re-challenge.
Re-challenge is the gold standard of proof. Did the event reappear when the drug was given to the patient again after the previous event had subsided? If it reappears, causality is basically confirmed as definite.
But this brings up a huge ethical problem.
A massive one. If the initial reaction was severe, say, liver failure or a life-threatening rash, it would be actively dangerous and completely unethical to re-challenge the patient. So it's very rarely done in clinical practice.
So in most real-world scenarios, the PV centers are relying on a combination of those first 3 criteria.
Exactly. The Naranjo algorithm assigns numerical scores to each of those criteria. If you have a highly plausible time relationship and you have a positive D-challenge, you move up the scale from possible to probable,
Which leads to the final grading.
The causality is ultimately graded. Definite, which usually requires a re-challenge. Probable, the likely cause, based on a strong score. Possible, meaning the drug and other causes could be responsible. And doubtful, where the drug is unlikely to be the cause, but you can't entirely rule it out. These grades are the foundation for any official regulatory response.
Now that we have the definitions and the system down, let's circle back and dive deep into the specific types of reactions, starting again with type A, the predictable ones. This category gives us some of the most fascinating paradoxes in pharmacology.
Type A reactions, or side effects, are inherent to the drug's action. They're unwanted, but often unavoidable pharmacodynamic effects at therapeutic doses. We mentioned postural hypotension from prazosin earlier.
Right, it's not serious in itself, but it can create a hazardous situation.
Exactly, leading to a fall and a serious fracture in an elderly patient.
But the paradox is where it gets really compelling. The material points out that an effect that is therapeutic in one context can be a side effect in another. It depends entirely on what you want the drug to do.
This illustrates that drugs don't just have one action, they have a whole spectrum of actions. We simply choose which action we want to leverage.
Give us an example.
Take atropine. We use it before surgery for its anti-secretory action to dry up secretions in the airway. That's the therapeutic goal. But that same mechanism inevitably causes dry mouth and blurred vision as unavoidable side effects.
Or, even more dramatically, codeine. If you're taking it for a cough, its antitussive action, it causes constipation as a side effect.
But if you have infectious traveler's diarrhea, you take codeine specifically because that constipation is the desired therapeutic effect.
It's the same effect, just viewed through a different lens.
Precisely. And digoxin, used for congestive heart failure, one of its effects is to depress AV conduction, which slows the electrical signal in the heart. If you have CHF, that's an undesirable effect. But if you have atrial fibrillation, that very same depression is the desired life-saving therapeutic effect you're looking for.
Here's where it gets really interesting, though. The origin story of new drugs. This highlights how side effects aren't just annoyances, they are literally sources of scientific discovery.
This is pharmaceutical serendipity at its finest. When the early sulfonamide drugs were being used as antibacterials, researchers observed 2 distinct unintended side effects in patients.
Oh, were they?
They caused hypoglycemia, low blood sugar, and acidosis. Now, the researchers didn't just ignore this, they recognized a new potential mechanism of action.
They saw an opportunity.
They did. Following up on those side effects led to dedicated research and the development of entirely new classes of drugs. The hypoglycemic effect led directly to the creation of the hypoglycemic sulfonylureas, which became a major class of anti-diabetic drugs.
And the acidosis.
The acidosis effect led to the development of the carbonic anhydrase inhibitor acetazolamide, which is a diuretic we use today for glaucoma and altitude sickness. Two major successful drug classes were born entirely from what were initially just unwanted side effects of another drug.
That is incredible. It really shows the investigative power required in this field, even in the lab.
Moving on from direct side effects, we also have secondary effects, which are more indirect consequences.
So secondary effects aren't due to the drug's core mechanism, but rather the disruption it causes in the biological environment.
Correct. The drug achieves its primary goal, but that very success opens the door for other problems to emerge.
What's the classic example?
Broad-spectrum antibiotics, like tetracyclines. They kill the target bacteria, which is what you want. But by suppressing the normal, healthy bacterial flora in the gut, they indirectly allow opportunistic pathogens, like certain fungi, to grow out of control, causing superinfections.
So it's an unintended consequence of success.
Or corticosteroids. They weaken the host's defense mechanisms, which can indirectly facilitate the activation of a latent condition like tuberculosis.
Finally, in this type A category, we have to address toxic effects and poisoning. These are always predictable, but they are severe extensions of the drug's normal action.
Toxic effects always result from excessive pharmacological action. They stem from either an overdosage or prolonged use, and they are always predictable and dose-related.
And an overdosage can be absolute or relative.
Right. An absolute overdose is intentional, like in a suicide attempt, or accidental. A relative overdose is when a usual dose becomes toxic because the patient can't clear the drug properly.
The classic example being kidney failure.
Giving a standard dose of an antibiotic like gentamicin to a patient with renal failure, the drug accumulates to toxic levels.
And the consequences are stark. You can have functional alteration, like high doses of atropine causing delirium, or you can have outright tissue damage.
Like the well-known hepatic necrosis from a paracetamol or acetaminophen overdose. This brings us to that distinction between a drug and a poison.
Right, the famous Paracelsus quote.
It is the dose which distinguishes a drug from a poison. Poisoning implies the harmful effects of a chemical that endangers life by affecting vital functions. Every single drug can be a poison if you take enough of it.
So if a patient presents in the emergency room with severe poisoning, we need to understand the immediate medical priorities. Let's do a quick crash course in detoxification.
The first priority, before you even know what the poison is resuscitation. You have to maintain vital functions.
Airway, breathing, and circulation, the ABCs.
It's non-negotiable. Severe poisoning often causes a loss of consciousness, which leads to loss of protective airway reflexes, a high risk of aspiration, and respiratory depression. Stabilizing the patient's breathing and circulation is the very first step in saving their life.
Once they're stable, you move to decontamination.
Removing the exposure. For surface exposure, that's fresh air or immediate washing. For ingested poisons, the mechanical methods are induced emesis, making them vomit, or gastric lavage, which is pumping the stomach.
But the sources are very, very cautious about these procedures.
There are crucial contraindications. You strictly avoid emesis or lavage in patients who are comatose or unstable because of the extremely high risk of aspiration,
Sucking stomach contents into the lungs.
which can be fatal. It's also contraindicated in kerosene or hydrocarbon poisoning, as those substances cause severe lung damage if aspirated, and it's generally not effective if the ingestion happened more than 2 hours ago. The stomach will likely be empty.
So if we can't mechanically remove it, the next step is to prevent absorption using activated charcoal.
Activated charcoal is given orally as a thick slurry. It works by adsorption, trapping many chemicals onto its huge surface area. It's very effective for most organic toxins, which includes most medications.
Was not a panacea.
Not at all. The source notes its big limitations. It does not absorb inorganic compounds like strong acids or alkalis, metallic salts like iron or lithium or cyanide. You might as well give the patient water if they swallowed a caustic cleaner.
Once absorption is blocked, the goal becomes elimination.
And elimination can sometimes be hastened. Techniques like forced diuresis are now largely abandoned because of the high risk of causing dangerous fluid overload. But hemodialysis remains a highly effective method for certain substances,
If the drug is dialyzable.
meaning it's small enough, not highly protein-bound, and water-soluble. We can quickly filter it out of the blood. This works very well for things like phenobarbital, lithium, and salicylate.
And finally, the magic bullet, specific antidotes.
For certain high-stakes poisons, these targeted reversal agents must be given as early as possible. There are a few critical examples to know.
Let's hear them.
Atropine is used for anticholinesterase poisoning, which includes many pesticides. Naloxone is the life-saving reversal agent for opioid poisoning, and flumazenil rapidly reverses benzodiazepine poisoning.
That covers the vast majority of predictable type A reactions. Now let's pivot entirely to the type B reactions, focusing on the peculiarities of the patient's own biology and their immune system. We can start with intolerance.
Intolerance is defined as the appearance of characteristic toxic effects at therapeutic doses. It's essentially an individual exhibiting a very low threshold for the drug. It's the converse of tolerance.
So if 90% of people can handle a standard dose with no problem, the intolerant person experiences a minor toxic effect from that very same dose.
Exactly. They fall on the extreme sensitive end of the population frequency curve. For example, some children will experience muscular dystonias or involuntary muscle contractions from a single therapeutic dose of triflupromazine.
Another example.
A patient might experience severe vomiting and abdominal pain from just one standard tablet of chloroquine. It's an exaggerated normal response, but it happens at an abnormally low dose.
Idiosyncrasy is the next type B category, and the sources give it a very distinct genetic definition.
Idiosyncrasy is pure genetics. It's defined as a genetically determined abnormal reactivity where the reaction is uncharacteristic of the drug's known action.
So the drug produces an effect that can't be explained by its normal pharmacology.
And it's restricted to individuals with a specific genotype. This is where we see those really bizarre, almost random-seeming effects.
Like what?
Well, barbiturates are central nervous system depressants. They should make you sleepy, yet in a small subset of patients, they cause the exact opposite effect: excitement, confusion, or delirium.
And the most serious example.
The most famous example, which carries very serious weight, is the antibiotic chloramphenicol, producing non-dose-related severe aplastic anemia in rare individuals. That reaction is catastrophic and completely unpredictable based on the drug's primary action.
Next, we move to drug allergy or hypersensitivity. This is clearly immunologically mediated.
This is the largest and most varied group of type B reactions. The core feature is that it is mediated by the immune system, and the symptoms are fundamentally unrelated to the drug's normal pharmacological actions.
An allergy requires prior sensitization.
It does, whether it was known or unnoticed. There's typically a latent period of 1 to 2 weeks before the immune system is fully primed to react.
So how does a drug, which is just a small chemical molecule, become something the immune system attacks?
It acts as what's called a hapten, an incomplete antigen. The small drug molecule is too tiny to trigger an immune response on its own, so it has to covalently bind with a larger protein in the body, like albumin.
And that complex becomes the real target.
That drug-protein complex becomes the true antigen, inducing the production of antibodies or sensitized lymphocytes. Then, upon re-exposure, even a tiny amount of the drug can trigger the full-blown reaction.
The cardinal features are clear then. The reaction is unrelated to the drug's action, and the severity is poorly correlated with the dose.
A minuscule dose can be fatal in a sensitized person.
Let's break down the 4 types of allergic reactions based on the Gell and Coombs classification, which defines the underlying immunological mechanism. Let's start with type I.
Type I is the anaphylactic or immediate type. This is the most acutely dangerous. It is mediated by IgE antibodies, which are fixed to the surface of mast cells and basophils.
What happens on re-exposure?
When the drug complex re-enters the body, the IgE cross-links on the cell surface, causing immediate degranulation and the rapid release of powerful chemical mediators: histamine, serotonin, leukotrienes.
And the physical manifestation of that chemical cascade is what we see as an allergic reaction.
Urticaria, which is hives, itching, angioedema, the swelling of the face or throat bronchospasm, and in the worst case, the life-threatening systemic drop in blood pressure known as anaphylactic shock. The onset is rapid, often within minutes to hours of exposure.
Okay, moving to type 2, the cytolytic type.
This is mediated by different antibodies, IgG or IgM. In this scenario, the drug binds directly to a component on a specific target cell, often a blood cell like a platelet or a red blood cell.
And the antibodies attack that cell.
The antibodies target and bind to the cell, activating the complement system, which leads to cytolysis. the destruction of those cells. This manifests clinically as hemolysis, the destruction of red cells, thrombocytopenia, destruction of platelets, or a granulocytosis.
Now type 3, which is called retarded or serum sickness.
Type 3 reactions involve circulating immune complexes. So this is the antigen, the drug, bound to the antibody IgG or IgM floating around in the bloodstream.
And these complexes are sticky.
Very sticky. They precipitate on the inner lining of blood vessels, activating a destructive inflammatory response. This leads to symptoms like rashes, fever, arthritis, and can cause serious widespread vascular damage, sometimes leading to conditions like Stevens-Johnson syndrome. Onset is typically 3 to 4 days after exposure.
And finally, type 4, delayed hypersensitivity.
Type 5e is the only one that is purely cell-mediated, not antibody-mediated. It involves sensitized T lymphocytes. When these T cells recognize the antigen, they produce inflammatory signals called lymphokines.
And this often shows up on the skin.
Right. It often manifests topically as contact dermatitis or photosensitization, and it takes 2 to 3 days to fully develop because the cellular response is just slower than the antibody response.
If a patient experiences a severe type I reaction, what is the immediate life-saving protocol? This is a crucial piece of knowledge.
The first non-negotiable step is to immediately withdraw the offending drug. For mild reactions, antihistamines might be enough. But for severe anaphylaxis or laryngeal edema, the sources are crystal clear.
And what do they say?
The only life-saving intervention is the injection of adrenaline, 0.5 milligrams, intramuscularly into the thigh.
Why is intramuscular administration so stressed?
Unless the patient is already in cardiovascular collapse and you need to infuse it very slowly under strict control, adrenaline should be given intramuscularly. Injecting concentrated adrenaline intravenously can cause a fatal cardiac arrhythmia.
So what does adrenaline do?
It works by reversing the core effects of anaphylaxis. It raises blood pressure, it relaxes the bronchial spasm in the lungs, and it reduces mucosal edema in the airway.
And after the adrenaline?
Adjuvant measures follow. We give H1 antihistamines, like phenyramine, intravenously to block the histamine effect, and we give intravenous glucocorticoids, like hydrocortisone.
Steroids don't work immediately, though, right?
No, they don't work fast enough to save the patient from the immediate shock, but they are crucial for prolonged reactions, and they're the primary treatment for type 2, 3, and 4 hypersensitivity reactions.
Let's quickly discuss another reaction linked to type PV, photosensitivity. This is a cutaneous reaction where a drug makes the skin hypersensitive to UV radiation. There's phototoxic and photoallergic.
Phototoxic reactions are the more common of the two. They're caused by the drug or its metabolite absorbing UVB light, which basically acts like an augmented sunburn, causing erythema and blistering. This is dose-related, it has a fast onset, and classic examples are certain tetracyclines or coal tar products. The mechanism is chemical damage, not an immune response.
Photoallergic, however, is a true immune response.
Correct. Photoallergic reactions are immune-mediated, triggered by UVA light, and they result in a picture that looks like contact dermatitis. Since it's immune-driven, it's non-dose related, and the lesions might even spread beyond the exposed area. Examples include some sulfonamides and grisafulvin.
And the prevention for both is pretty straightforward.
Strict avoidance of sun exposure and the use of broad-spectrum topical sunscreens.
We've covered immediate and short-term risks. Now let's tackle the most high-stakes, long-term consequences of drug use. Let's start with the distinction between drug dependence and addiction, an area that is full of social and regulatory confusion.
The precision here is paramount because of the huge legal and social consequences. Drug dependence, which is often called physical dependence, is an altered physiological state. It's a neuroadaptation produced by repeated drug use.
The body literally requires the continuous presence of the drug to maintain equilibrium.
And if you stop, you get the characteristic withdrawal or abstinence syndrome. This is common with depressants like alcohol, opioids, and benzodiazepines. The body has adapted its chemistry around the drug's presence.
So how is that different from drug addiction?
Drug addiction is primarily behavioral. It's defined as a pattern of compulsive drug use where procuring and using the drug takes absolute precedence over all other basic needs, obligations, or goals. The individual feels emotionally distressed if the drug is unavailable. This is what used to be called psychological dependence.
And here is the crucial insight that regulatory bodies have to grapple with. Physical dependence is not essential for addiction.
This is key. Drugs like amphetamines, cocaine, cannabis, and LSD produce profound addiction, that compulsive drug-seeking behavior, but they produce minimal or no physical dependence. There is no severe life-threatening abstinence syndrome when you stop. The drive is purely psychological.
And that compulsive drive relates back to reinforcement.
Reinforcement is the ability of a drug to produce immediate, intense, pleasurable effects, which strongly induce the user to seek it out again. This is heavily influenced by the speed of onset.
The faster the drug acts.
The more intense reinforcing it is. So a drug that's inhaled, smoked, or injected intravenously is more reinforcing because the brain immediately associates that rapid pleasure spike with the drug-seeking behavior.
We also need to define the term drug abuse.
Drug abuse is a regulatory and social term. It simply means the use of a drug in a manner or amount that deviates from approved medical and social patterns in a given culture. It could be the continuous use of prescription opioids beyond a therapeutic need, or the recreational use of illicit substances.
And finally, under this banner, we have to acknowledge that withdrawal reactions can happen even with drugs that don't cause traditional dependence.
Yes, this is due to physiological adaptation. The sudden interruption of certain non-dependence drugs can still cause severe adverse consequences. We see this clearly with corticosteroids.
What happens there?
Abrupt cessation, even after short-term use, can precipitate acute adrenal insufficiency because the body's natural cortisol production has been suppressed. Similarly, suddenly stopping beta blockers can lead to a dangerous rebound effect, worsening angina, or even triggering a heart attack. These are all warnings that must be considered.
Now we move to arguably the most ethically sensitive long-term risk.
Teratogenicity, the capacity of a drug to cause fetal abnormalities. This is a defining risk for any drug used in populations of childbearing potential. The core truth here is that the placenta is not a strict barrier. Virtually all drugs cross it to some degree.
And the developing embryo and fetus are incredibly vulnerable.
They are highly dynamic systems, and drug effects during these critical phases can be catastrophic and irreversible.
The entire field of drug safety was, well, irrevocably changed by the single worst instance of teratogenicity in history: thalidomide.
The thalidomide disaster from 1958 to 1961 remains this dark watershed moment. It was prescribed widely as a sedative and for morning sickness. Its use in the first trimester resulted in thousands of children being born with phocomelia,
The devastating congenital malformation with severely reduced or seal-like limbs.
and other severe defects. That historical tragedy led directly to much stricter global regulation of prenatal drug testing and safety.
And the risk depends critically on the stage of gestation. The sources divide this into 3 highly vulnerable periods.
The first stage is fertilization and implantation, from day 0 to day 17. Exposure during this period often results in the failure of the pregnancy entirely, which may go unnoticed.
The second stage is the most critical.
Organogenesis, from about day 18 to day 55 of gestation. This is the most vulnerable period. This is when the major structural components of the body, the heart, limbs, nervous system, are forming. Exposure here is what produces those major structural deformities.
And the third stage.
Growth and development, from 56 days onwards. Exposure here typically causes developmental and functional abnormalities rather than gross structural defects. For example, ACE inhibitors used late in pregnancy can cause hypoplasia of organs, and NSAIDs can cause the premature closure of the fetal ductus arteriosus, which can be fatal.
The source material lists specific known human teratogens that are clearly associated with causing these defects.
Yes, drugs like the anti-cancer agent methotrexate, which causes hydrocephalus. The anticoagulant warfarin is linked to bone and eye defects. Isotretinoin, used for severe acne, is a potent teratogen causing severe craniofacial and CNS defects. And even common substances like high consumption of alcohol are linked to fetal alcohol syndrome.
So the preventative advice is simple but crucial.
Avoid all unnecessary drugs during pregnancy,
And we must also mention the importance of folate therapy.
which is known to reduce the frequency of spontaneous malformations like neural tube defects, and it can potentially reduce the incidence of drug-induced malformations as well. It's a key preventative measure.
We also have to consider the risks that play out over decades: mutagenicity and carcinogenicity.
Mutagenicity is the capacity of a drug to cause genetic defects, and carcinogenicity is the capacity to cause cancer. The mechanism often involves drug oxidation, resulting in highly reactive intermediates that can directly damage DNA structure, genes, or chromosomes.
And if that damaged DNA regulates cell growth,
It can lead to tumor growth. The big problem for regulators, of course, is the timeline.
the timeline is staggering, and this is why post-marketing surveillance is so crucial. Chemical carcinogenesis typically takes several years, often 10 to 40 years, to develop.
This long latency period means these risks are virtually impossible to catch during the initial few years of clinical trials. Drugs implicated include certain anti-cancer drugs, radioisotopes, and estrogens. Regulators only approve or maintain drugs with known carcinogenic potential if the drug is deemed useful in life-threatening conditions, where the immediate benefit outweighs the decades-long probabilistic risk.
Finally, we have to address drug-induced diseases, or iatrogenic diseases.
These are functional disturbances or outright diseases caused by drugs that persist even after the offending drug has been withdrawn. They represent structural or functional damage to the body that was caused by the physician's intervention.
So the damage lingers long after the pill is gone.
Exactly. Classic examples include NSAIDs or corticosteroids causing persistent peptic ulcers, or phenothiazines causing a persistent drug-induced Parkinsonism, or the antibiotic isoniazid causing chronic hepatitis.
This has been an incredibly deep dive into the full spectrum of risk, from the trivial side effect to the long-term, delayed, fatal consequence. To wrap up, let's summarize what practitioners, and frankly what you, the patient, can do to minimize these adverse drug effects.
The sources outline 7 essential practices that really focus on vigilance and control.
Number 1, avoid all inappropriate use of drugs. If the risk outweighs the benefit, you need to find another path.
Number 2, always tailor the dose, the route, and the frequency based on specific patient variables, age, weight, and crucially, their renal or hepatic function. A standard dose is not standard for everyone.
Number 3, always elicit and meticulously review the patient's previous history of drug reactions, especially allergies. This single step can prevent life-threatening type B reactions.
Number 4, exercise extreme caution regarding drug interactions when prescribing multiple medications. This requires deep pharmacological knowledge, especially when treating the elderly, who often have very complex medication regimens.
Number 5, adopt the correct administration technique. This is surprisingly important. For instance, the instruction to give vancomycin as a slow intravenous injection, not a rapid push, is essential to avoid the red man syndrome reaction.
And number 6, carry out appropriate laboratory monitoring. This is what converts a predictable type A risk into a manageable one. Monitoring prothrombin time with warfarin or checking serum drug levels with lithium ensures the drug stays within that therapeutic window without crossing the toxicity threshold.
That brings us to our final takeaway. We've clarified the crucial distinction between an adverse effect, an adverse drug reaction, and an adverse drug event.
And we've reinforced the immense biological difference between type A predictable reactions, which stem from known pharmacology, and type B bizarre reactions, which stem from the unique, sometimes chaotic biology of the individual patient.
And we've stressed the critical, albeit imperfect, role of pharmacovigilance and causality assessment in ensuring that medicines become safer over time, post-approval, relying on the ongoing collection and analysis of reports from the real world.
This systemic reliance on decades-long surveillance and these difficult risk-benefit calculations are the reality of modern medicine.
As we sign off, let's consider the provocative thought for you, the listener, building on these long-term risks.
We discussed how the risk of an adverse reaction must be balanced against the benefit, and how that often justifies severe side effects for serious diseases. But considering the timeline we saw for chemical carcinogenesis, 10 to 40 years, and the fact that many drugs are approved without the decades of safety data required to rule out low-grade teratogens or carcinogens, we have to ask a question.
What's the question?
How much scientific certainty should regulators demand before approving a drug for a non-life-threatening condition, knowing that some of the most serious long-term effects may only become visible decades after global exposure, long after that drug has become a financial and clinical mainstay of therapy?
The ultimate question of immediate need versus a delayed and perhaps unknown consequence. Thank you for guiding us through this essential deep dive into pharmacovigilance. We'll see you next time.